Great. So thank you very much for that introduction, folks. And I'm really looking forward to speaking with you for the next little while about cultural safety for Indigenous people as a determinant of Indigenous people's health. I just want to quickly say I'm really thankful to one of the participants who observed that in any lecture about cultural safety, it's really imperative, particularly for settler colonial subjects, to kind of locate ourselves. I'm giving, for instance, this lecture from my office in the city of Kelowna in British Columbia on unceded Okanagan Nation territory. I have Dutch heritage. Grew up on Haida Gwaii on the Queen Charlotte Islands and in northern British Columbia more broadly. And I come to conversations about Indigenous health and well-being from years of living in Indigenous territory and really witnessing firsthand as a non-Indigenous settler subject the disparities lived and experienced by Indigenous people from my vantage point, particularly in northern British Columbia. So I just want to say that recognition of our own place and privilege in these conversations about cultural safety, particularly if we are not Indigenous people, is a very important place to start from, to start these conversations. So with that, just a quick overview of where we'll go in the next hour and a half. I'm going to begin with a very brief introductory question, which I'll put out to all of you as participants. And I'll ask that you fire in your one word or couple of word answers, and we'll then talk about those answers and sort of what they mean. Hopefully that will set the stage, so to speak, to broader conversations about what the determinants of health for Indigenous peoples are. The second part of the lecture then will be really a conversation about what we mean when we say determinant of health. I'm going to review some of the literature and conversations and research and evidence about cultural safety. I'm going to move specifically into a conversation about anti-Indigenous racism. In order to do that, we're going to overview quickly who Indigenous people in Canada are. I realize that for many folks listening and participating in this webinar, some of this background information might be quite axiomatic. It might be things that you really know. But we don't want to forget that there might be some people who are participating in this conversation who might not be quite as fluent in others about the constitutionally recognized three groups of Indigenous people in the country. So I do want to just lay some of the groundwork and then hopefully move into some conversations about how, particularly as non-Indigenous healthcare providers, policymakers, researchers, or people who work with Indigenous people, we might work toward and ensure cultural safety for Indigenous people. I'm not here suggesting that Indigenous people don't have an extraordinarily important role to play, and certainly it's incumbent upon non-Indigenous settler colonial subjects to listen acutely and with sensitivity to the voices and experiences of Indigenous people. But as a non-Indigenous researcher and thinker about determinants of Indigenous people's health, one of the things that I'm going to focus on is cultural safety for Indigenous people. And that's often with regard to how cultural safety is actualized, particularly by non-Indigenous people. I'll spend about 15 minutes then looking at the experiences of Indigenous people who have interacted with what I would argue is a very exclusionary and often a racist healthcare system in Canada. We'll move to thinking about ways that we may indigenize or make more culturally safe our practices and perspectives. And then hopefully in the end of this webinar, we'll open things up for questions and conversations, allow for about 20 minutes of a more interactive engagement. Okay, folks, in the next minute or two, if you would quickly, and again, without thinking too much about it, write in the question pane of this webinar, write out the words that you think of in terms of when they first come to mind when you hear Aboriginal people, health, and Canada. I'll just let us sit with that for a minute, and I'll start to see the words pouring in. I can see people typing away and really putting quite a lot of effort into that quick response. Lots of people typing things in very quickly. A lot of words really jumping out. I'll start to read some of them. I've got discrepancies, disparities, disproportionate rates of everything, limited cultural appropriateness, bad access, colonialism, poor health outcomes, poor health, poverty, racism, remote, second-class people, underfunded. Oh, I've got lots of underfunded, unfair, frustrating. I've got forgotten. Let's let a couple of more words pour in. Again, a lot of focus on really the problematic issues facing Indigenous people in the country. Okay, that's great, folks. I'll just stop you there and I'll move into an open conversation about the words that are posted. And I will say that I do this exercise fairly regularly. I would encourage any of you who are in environments where you have the capacity to do this kind of exercise to follow the template of this exercise and do it in your own groups and professional settings. The reason it's an important exercise to undertake is because in every instance that I run this exercise, the vast majority of the words that come to people's mind when they're asked to think about Aboriginal people's health and Canada are words that can be described as negative descriptors. They are somewhat tragically not positive descriptions that come to people's minds when they talk about or think quickly about Indigenous people's health in Canada. And I'll just add a little note here that it's very interesting to me that an incredibly wise Cree elder by the name of Willie Ermine, I'm sure many of you have heard of Willie Ermine. He's worked for years in the area of Indigenous people's health. One of the things that he's argued is that a pervasive lens of pathologization continues to frame the way we understand Indigenous people, and that this pathologization of Indigenous people discursively, conceptually, continues to be a significant colonial tool to frame Indigenous people as always sick subjects in the country, as always in need of some kind of particularly settler, colonial, non-Indigenous salvation. These pathologizing words not only discursively produce Indigenous people as constantly sick and as constantly sort of second-class healthcare citizens, but they continue to also reinforce the primacy and the paternalistic, salvation-imbued reality of non-Indigenous settler subjects vis-a-vis Indigenous patients, which is, in fact, as Willie Ermine argues, exactly the kind of historic colonial lens through which settler colonial subjects positioned and viewed Indigenous people. I should observe that some of the words that you folks typed in were, in fact, positive descriptors. There were incredible words like strong and resilient and holistic healthcare approaches, holistic medicine, traditional medicine. And those are really amazing words to keep in mind when we think about Indigenous people's health in Canada, that there is, in fact, a really strong history of incredible resilience in the country. But those tend not to be the conceptualizations that many of us hold and have, maybe even unconsciously, about Indigenous people and Indigenous people's health, particularly, I would argue, when accessing the healthcare system. So to put this even more bluntly, I'll share with you the results of this exercise that I did really recently with a group of family practice residents in British Columbia. So I supervise family practice residents. I'm sure, again, this is common knowledge for all of you, but residents are folks who have completed their undergraduate medical degrees. They are practicing MDs, but they haven't yet fully ascended into their own independent practice. They're just sitting on the cusp of moving into their own practice. When they were asked to think about Aboriginal people, Canada, and health, they used words like drug seeking, obesity, type 2 diabetes, tobacco, reserves, adolescent pregnancy, isolated, and addiction. Now, I pointed out to them the incredibly pejorative nature of these sorts of words, the bordering on Indigenous racist stereotypes that things like drug seeking or addiction brought to mind when they were using those words in reference to Indigenous people's health in Canada. And many of them were aware of this sort of problematic construction that they may hold in their minds about Indigenous people, but they weren't entirely sure how to tackle that, how to really sort of break that down. And I would argue that that's exactly where concepts of cultural safety enter the conversation, and really the need for targeted and thoughtful and fulsome conversations about cultural safety and about anti-Indigenous racism need to come into mainstream play, particularly for healthcare providers, healthcare professionals, and the rest of us involved in conversations about Indigenous health realities in the country. I want to make clear, and I really did make clear to the residents that I was dealing with, that I'm not out to cast stones here. I'm not out to say, gosh, there's a bunch of healthcare professionals, there's a bunch of non-Indigenous settler subjects who are meanie, batty bads out there who are, filled with a conscious anti-Indigenous racist agenda here. What I want to point out, and again, I'm not stone casting here. I'm not trying to be mean to people who may, in fact, have words like drug seeking in their mind when they think about Indigenous people and health and the Canadian system. What I'm suggesting is that we really live, most of us have been fully acclimatized, steeped, if you will, in a cultural climate that dates back really to the formation of this country, the development of Canada as a geography that we now know. This cultural climate has been systematic in producing Indigenous people as marginal, pathologized subjects who are constantly in need of the well-intending settler subject. We can see here an image of Thomas Moore, who is, so grotesquely, I would argue, photographed in the late 1800s as a testament to the civility, to the sort of healthy, inducing gaze and input of the settler subject through the residential schooling system. We can see this savage transformed into an upstanding settler colonial citizen. That kind of narrative is precisely the kind of narrative that I would argue we have all been steeped in for so long, and we really consciously or unconsciously, innocently or even with good intention, it's the kind of cultural climate that we bring into the healthcare system. We bring into interactions and constructions of Indigenous people. I would argue that this is exactly why it is that we have to engage more fulsomely in a conversation about cultural safety, because it is only if we, in a very conscious and effortful manner, start to peel back and unsettle the cultural climate that comes so naturally to us because we have been so steeped in it. If we begin to unsettle that cultural climate, we can begin to think anew about healthcare provision and the healthcare climate for Indigenous people in Canada. All right, a little bit more in terms of the background and context to the discussion that we'll be having today. Most importantly, we can begin with a conversation that sort of talks about the determinants of health. What are determinants of health? What are those and where have they come from? So a couple of things. The very conversation about determinants of health is a relatively recent conversation. If you look sort of, for instance, at the history of medicine, which is going on about 175 years old, can kind of trace that back to the Flexner report 160 odd years ago. There was really an emphasis on the reproducibility of sort of scientifically informed biomedical efforts at health interventions. So we can think, for instance, of sanitation, we can think of pasteurization, we can think of antibiotics, we can think of a series of solutions to health challenges which focused on disease, which focused on solving an illness, and which focused on a bioscientific modality of understanding poor health in individuals and sought to rectify individual aspects of a person's physiological, physioanatomical body or their individual life choices. That those sites were considered imperative if we were to intervene into people's health and well-being. In the last 20 years or so, that's really shifted. No longer is it understood that we'll solve some of the largest global disparities between people's health by simply focusing on eradicating disease or shifting individual choices about health realities. Instead, and just for the record, because I like to historicize some of these conversations, really coming out of the Ottawa Charter in the mid-1980s, so located within a Canadian context, there has been a realization and an acceptance that there is a socially determined nature of health inequities. So what that is in terms of the World Health Organization's categorization of this, it's conceptualized as whether people are healthy or not is determined by circumstances and environment. To a large extent, factors such as where we live, our genetics, our income and educational level, our relationship with friends and family, our sociocultural contexts, those all have considerable impacts on health, as opposed to more commonly considered factors such as access or use of healthcare services. It's still important to note, however, that health services and the access and use of those services to prevent and treat disease is an influence of health. And the argument that I'm going to put before you today in terms of cultural competencies and cultural safety really rests on an increasing body of evidence that suggests part of the challenges faced by Indigenous people is that they are treated as second-class citizens within their access to healthcare services. So let's also do a little bit of background in terms of what cultural safety is. Again, for many of you, this might be common knowledge, but we'll nevertheless have a conversation about where the very idea of cultural safety originated. So, as many of you may know, we can chart the concept of cultural safety back to nursing education in New Zealand. And what those early researchers and practitioners and educators really sought to validate is that cultural safety recognizes, respects, and nurtures unique cultural identities of especially marginalized cultures and looks to safely meet their needs, particularly inside a healthcare professional/patient relationship, what we might term the clinical encounter. So again, cultural safety, particularly within a health service environment or a clinical encounter environment, looks to identify the power relationships between the service provider and the people who are using the service. It seeks to empower the users of the service. So it's really de-emphasizing the rights of the service provider and seeking to privilege the user of the service. It's really seeking to prepare healthcare providers to understand the diversity within our own cultural reality. That's very important. Again, harkening back to my opening introduction where I placed and gestured towards some understanding of my own cultural locatedness in an effort to understand, again, an important component of cultural safety, the impact of my cultural and cultural reality and cultural specificity, the potential impact of that on a person who might differ from that, from my own cultural reality. And if we link that back to an effortful work toward identifying the power relationship, I might be able to more fulsomely understand that my position as, first-born Canadian child of a Dutch father, not Indigenous, that has an implication for the way I relate to, in this case, an Indigenous patient, and importantly, how an Indigenous patient may relate to me. And so then the fourth part of cultural safety is to really apply social science, and I would argue some humanities concepts that underpin practices of healthcare. So again, not privileging purely biomedical modalities, but really bringing in social science and humanities concepts that may allow more nuanced and fulsome appreciation of things like power imbalances and power relationships, so that there is something more than just healthcare practitioners carrying out objective, non-socially constructed tasks. But instead, we really need to relate and respond effectively to people who do have diverse needs and diverse strengths. Those strengths are very important in recognizing when they're using the healthcare services that have to, in turn, be defined as safe. One of the things that cultural safety relies on, just to harken back to that last slide, is that recognition of differences of power modalities between the subjects within a clinical interaction. And if we go back to some of my early conversations about sort of colonial constructions of Indigenous people, and then tie that in for the need to recognize power imbalances, one of the things that is increasingly being argued as an absolute component of an unsafe cultural encounter in the clinical relationship has to do with racism. And there's a lot of broad definitions about racism. And one of the things that this webinar will do is argue that there's very particular articulations of racism that can be defined as anti-indigenous racism. But broadly speaking, if we're just speaking about racism writ large as opposed to anti-indigenous racism particularly, racism is the notion that there's this inherent difference among various human races. And I can tell you this concept is an utter fiction. It is the notion that there is a difference between race based on color and hue of skin, dates back to Linnaean preoccupations with taxonomies and characterizing and classifying species. You know, there really is no inherent genetic difference between me as somebody who hails from a rather light-hued environment of the Netherlands and somebody who hails from, a geography where phenotyping and skin type is different than people from the Netherlands. But this Linnaean historic preoccupation with classifying human subjects particularly led to a fiction of difference between races, this notion that races are somehow biologically determined, and then presuppose that one's own race is superior and has rights over ruling other people. So really, again, racism is defined as a belief that race is a primary determinant of human traits and capacities, and that racial differences produce an inherent superiority, a kind of hierarchicalizing of human beings based on race. And I think that one of the things that cultural safety really needs to account for is the very notion that race is a means of hierarchicalizing human subjects, which I would argue increasingly is being used to problematic ends. And that's not to suggest that the racialization of people isn't a very real phenomenon and doesn't absolutely result in racism, but that instead we can sort of push back against the very concept that race is an inherent way to categorize and to classify in a hierarchicalized manner human beings. Again, I would point you towards some excellent, I'm being slightly biased since I co-authored one of them, resources produced by the National Collaborating Centre for Aboriginal People's Health that does look at the way racism behaves as a social determinant of health and the way that race and culture, ethnicity, and ethnocentrism are all categories that potentially can be deployed either in a pathologizing manner toward Indigenous people or conversely, and I would argue if we fully account for the potentials of cultural safety as a way of unsettling the kinds of race-based and racialization-based relationships between healthcare providers and Indigenous people. So Indigenous people, I would say, are absolutely particularly positioned as a kind of racialized entity inside of Canadian discursive imagination. But certainly race and racism are also an aspect of determinants of other people's health as well. Not a lot of evidence has been accrued on the actual impact of race and racism within the healthcare system. This is an increasing conversation. But back in 2009, there was quite an important document about immigrant health and about differently racialized bodies in Canada, about the health of those specifically racialized people in Canada as a determinant of their health, specifically because of their engagement with the healthcare system. So I just want to draw your attention to almost 1 in 5 study participants reported that they'd experienced racism in the healthcare system. Again, this is not specific to Indigenous people. I'm going to turn to a conversation about Indigenous people in one moment. But broadly speaking, about differently racialized bodies engaging with the healthcare system. 1 in 5 reported experienced racism in the healthcare system, including being subjected to name calling and racial slurs. 8.6% found doctors to be culturally insensitive or ignorant. 6.2% reported receiving inferior quality of care. So just in the words of one study participant, which I think really gestures strongly to the reason why we must in this country pay critical attention to questions of cultural safety, the participant says they were coming from a completely different culture. And I would argue they didn't, this is probably unrecognized by the healthcare professional. They didn't understand my culture, and it didn't seem like they made an effort either. It was more just like, well, it shouldn't be that way. And it's almost like my own culture was being put down. So I would argue that that is absolutely at the heart of the reasons that we need cultural safety training and cultural safety awareness in this country. Now, that was a study half a decade ago, specific to immigrant and racialized folks in Canada. This now last year, a remarkable report really driven by Dr. Janet Smiley was published. It is an absolutely phenomenal report. I suggest that after this webinar, all of you, if you haven't already, go out and read it. First People, Second Class Treatment. And it really is, I would say, a groundbreaking document on the role of racism in health and well-being of Indigenous people in Canada. And it really argues that part of the role, the deleterious role of racism toward Indigenous people sits at the scale of health service delivery. It impedes Indigenous people's ability to interact with healthcare professionals in a meaningful and open way. So I think that that is sort of a call to awake us in this country. Please do read it. I think it's really an eye-opening report. It speaks about the role of racism very broadly. I mean, I think we need look no further than things like the recently agreed to need for an inquiry on murdered and missing Aboriginal women in this country, the Truth and Reconciliation report and recommendations to know that racism is alive and well for Indigenous people in this country. But most specifically, and really the focus of this conversation and webinar, is the way it sits within healthcare service delivery environments, really the way healthcare professionals, doctors, nurses, social workers, folks involved at the front lines of healthcare provision in this country, the way racism operates in those environments, And given that it operates the way it becomes a determinant of Indigenous people's health, and consequently, the real imperative for all of us to start thinking in an impassioned and alive way about cultural safety and the need for it in our practice and daily orientations to the world. Just to sort of really drill down and make specific the questions that Smiley's report, First People, Second Class Treatment, explicated, that anti-Indigenous racism is different than the kind of anti-immigrant racism or, racism against specifically racialized people in Canada. I'm here to tell you that, of course, that exists. But I'm also here to say that anti-Indigenous racism is very specific. It has been honed and produced and discursively reproduced in really specific ways in this country, really since the moment of contact. And there are very specific kinds of contours of that. I would argue that, for instance, in British Columbia, where the vast majority of the province is unceded traditional Indigenous territory without treaties, without negotiation with the Crown, there's a really particular tenor and tension to anti-Indigenous racism that often is anchored in a feeling of uncertainty by settler colonial subjects, this feeling of somehow being under pressure from the very people whose land was, stolen. I would argue that it often relies on this pathologizing lens in very specific ways, infantilization, inferiority, and insistence on Indigenous bodies being somehow sickly and always in requirement of the care and good intentions of settler colonial bodies. If you want to read more on kind of settler fragility and sort of the good intentions of non-Indigenous settler colonial people, please feel free to refer to people like Sarah Ahmed, S-A-R-A, Ahmed, A-H-M-A-D. She does a really amazing job at kind of thinking through why it is that particularly white settler colonial bodies get so anxious when we're confronted with the kinds of power that we hold. Why do we get so anxious and feel weepy and upset about ourselves when we're told, look, you are absolutely complicit in a regime that has always been anti-Indigenous and racist from its earliest incarnations. So yeah, Sarah Ahmed, but again, we do touch on these conversations in the fact sheets that were published by the NCCAH. So again, I would recommend you download those. They make for, I'd say, riveting and accessible reading. Before we move on to sort of lived voices and experiences of Indigenous people, I'm going to draw your attention to, I'd say, really one of the most upsetting cases that I've been made aware to me, and I would argue been made aware to all of Canada. Really, I think a wake-up call. It has to be a wake-up call because, otherwise, tragically, Brian Lloyd Sinclair may never ascend to the place that I would argue he must ascend to in this country, which is an understanding that Brian Sinclair was an Indigenous man left to die at the very site of healthcare service provision in the emergency ward in this country. So there was a fairly significant inquiry undertaken. I would suggest to you that many Indigenous people felt that this inquiry didn't go far enough. Certainly, Brian Sinclair's family said that it didn't go far enough because it didn't actually overtly state that racism and anti-Indigenous racism was at the heart of Brian Sinclair's death. But it does gesture toward that. It does talk about how colonialism has an impact on structures and outcomes for Aboriginal health. It cites Indigenous healthcare providers. It cites people who are Aboriginal and who are engaged in questions about Indigenous people's health and well-being. And it argues that there are these racist ambiguities in the healthcare system that ultimately are a determinant of Indigenous people's health. But I would draw your attention to one of the recommendations of the inquiry on the Brian Lloyd Sinclair report, which is that people in the Winnipeg hospital receive cultural safety training. And I would argue that any kind of immersion and critical thought into cultural safety is, in fact, it's something that all of us should be doing if we have really any interest, I would argue, in trying to combat these massive issues of anti-Indigenous racism operating at the specific scale and site of healthcare service delivery in this country as it impacts the well-being of Indigenous people. So, on the off chance that I have any skeptics in terms of contemporary anti-Indigenous racism and the way it forms sort of a socio-cultural and I would argue healthcare climate in this country, I hope I managed to convince you that racism is tragically very much alive in this country today just by drawing your attention to the tweet that circulated prior to this particular webinar yesterday. But I'll turn our attention to a really, in my estimation, emblematically contemporary debate about anti-Indigenous racism in this country that the Canadian Broadcasting Corporation, CBC, just elected to turn off anonymized responses to news stories about Indigenous people in this country because they found that violent racism that formed the vast majority of responses to CBC postings about Indigenous politics and peoples and conversations in this country, that those responses were so vile, they were so violent that actually opening up the environment to those voices created an unsafe environment for Indigenous people in this country, having to see oneself represented in the most horrifying of ways was really at the heart of so many responses to stories about Indigenous people in this country. And, as a settler colonial subject who thinks about issues of race and racism and the construction of Indigenous people by settler colonial presences and subjects in this country, I found these responses, and I'm going to share them with you here. If you haven't seen this video, it's worth watching, but we'll just share it quickly today. They're read by Indigenous employees of the CBC, Indigenous people who are spending and dedicating their careers to bringing Indigenous voice to the public forum. And these are the kinds of comments and responses that they have to live with. And I would argue that form a much larger sort of discursive socio-cultural climate that ultimately bears down at the site and location of health service provision in Canada, and that is tragically and potentially embodied by so many of us at the front lines of healthcare and health service delivery and even health research and health policy in Canada. So this will offer me the opportunity to catch my breath, and I'm going to switch it over to David and Lisa, who will play this video for you. So I'll just quickly recognize that for many people on this webinar today, hearing that kind of violent racism may be triggering. I know it crumbles my heart and makes me livid every time I see this video. But I deeply believe that it's incumbent upon particularly non-Indigenous settler colonial subjects to understand that we exist in this climate. We all act and live and work inside an environment, inside a country where these kinds of sort of blaming racist and very emblematically anti-Indigenous racist discourses occur, ones that at their heart take as sort of a given lifestyle choices as linked to poor health, as sort of ubiquitous addiction and violence as a normalized component of Indigenous people's lives.
These are absolutely heinous fictions, racist fictions about Indigenous peoples, but they're circulating right now. That yesterday somebody would tweet and say that conversations about cultural safety are potentially an affront and an undermining of her right to be an academic. These are systemic, long-standing, and resilient narratives. And I would argue that they really need to be accounted for by us carefully if we are to move toward a place of culturally safe health practice, health research, and health policy. So with that in mind, I just want to kind of take us out for the next 10 minutes or so with some sort of, dare I say, easy ways that settler colonial people might be able to understand and enact and think critically about cultural safety in practice so as to disrupt any of our own, sort of modalities and orientations to the world vis-a-vis Indigenous peoples, communities, nations, governments, and constitutionally recognized people of this country. So I think one of the most important things to do is to change and to challenge the discourse. It's absolutely remarkable to me how pervasive this kind of anti-Indigenous discourse is. It's imperative that we don't just let it lie when we see conversations on CBC, letters to the editor. When I get tweets, I respond personally and say things like, "Dear Twitter person, your response to the notion of cultural safety being an affront to your academic freedom is anchored in anti-Indigenous racism. It is a fictitious affront and you need to address that." So we have a responsibility to intervene. I get, folks, that this can be really hard, but just think about it. Please give it space in your mind that we have the capacity to intervene. There are multiple strategic and different ways of intervening. You can write a letter to the editor in response to something. You can reach out within your own communities. You can teach and practice differently, and you can be constantly aware. I can be constantly aware of the need to reflect, to historicize, and to think critically, to always demand that these larger conversations be contextualized and understood within a historic climate of anti-Indigenous racism and marginalization of Indigenous peoples, violent, often genocidal marginalization of Indigenous people in the country. So again, intervene in any way that you can. It's kind of my life work. I write everything from books to poetry through to academic textbooks about the remarkable resiliency of disparities in this country and the power and privilege that non-Indigenous settler colonial subjects continue to hold and to wield. But if we hold it and if we wield it in poor ways, we can also hold and wield it in positive ways. I really do believe that. We can intervene, we can change and reflect and historicize and critically alter our own behaviors and our own modes of conversation. So there's other slightly more complex ways of undertaking, combating anti-Indigenous racism and orienting to the world in a culturally safe way. I would argue that experiential learning is a remarkably pedagogically sound and well-evidenced way of going about this. So, for instance, one of the things that I do in the Faculty of Medicine at UBC in partnership with the First Nations Health Authority and Northern Health in British Columbia is I organize student immersion opportunities in Northern First Nations communities. And the really fundamentally important part of these experiential learning opportunities for undergraduate medical students who will go on to become, sort of the crème de la crème, the elite of healthcare professionals, because that's sort of the discursive construction of physicians. I'm not necessarily agreeing with that, but certainly physicians wield and hold a particular kind of power. And by immersing physicians in training, undergraduate medical students in First Nations communities, not as experts, not for any rarefied experience, but simply for a day-to-day hanging out with, living in a home with, tagging around with, playing games, going fishing, going hunting, getting out on a quad, doing whatever it is. That kind of experiential learning, in my estimation, really goes a long way to disrupt the kind of pathologizing, othered, anti-indigenous, racist, discursive formulation that many of us carry around with consciously or unconsciously. I would argue that listening and working in partnership with Indigenous people is an intensely important component of culturally safe practice. Of course, knowing ourselves and our own cultural, sociocultural, historical subjectivity and positionality is vitally important. But working in partnership and seeing what one can do without interest in our own agendas through partnerships with Indigenous organizations is vitally important. Now, Dr. Margot Greenwood and I and another scholar have written on the importance of foregoing instrumental or targeted understandings. So rather than entering any kind of interrelationship with Indigenous communities or people or organizations with sort of a set learning agenda, okay, I am going to form a partnership to answer this question. That tends to continue to privilege an instrumental orientation to Indigenous peoples and communities. Instead, I would argue that it's very important to just hang out, to put aside any predisposed, instrumentalized, and targeted modalities of your own efforts. Go, go to a weaving circle or a ladies stitch and bitch group somewhere and just hang out and understand yourself vis-a-vis the Indigenous peoples who surround you. People are incredibly open, I would argue, from coast to coast to coast, and inherent to being open-minded is to recognize your power and account for it. So yeah, expand and engage. And I would argue that one of the most profoundly and poorly utilized ways of engaging and expanding understandings about Indigenous people is to seek out new cultural learnings and modalities. So don't, please, folks, for all of those of us who are non-Indigenous settler colonial folks in the country, don't go running to your local friendship center and plunk yourself down and say to people, please teach me about indigeneity. For goodness sake, these folks are overworked, underfunded, have lots of, confusions and complexities in their own life. The last thing that they may want to do is invest their precious time educating a bunch of naive non-Indigenous folks. But the beautiful thing is this country is rich with arts and literatures and movies and plays and comedic practices and a remarkable wealth in the archive and on the public record of Indigenous people's voices. So these can be sought out and engaged with. We don't necessarily need to take and impose upon the precious time of Indigenous peoples and communities for them to, quote unquote, teach us. And here I'm thinking of a remarkable Black feminist colonial scholar from the 90s, Audre Lorde, who said really remarkably, it's not my job to teach you, it's your job to learn. So again, I would argue that these opportunities and possibilities exist around us. That's not to say that one of the most powerful learning opportunities is, in fact, to ask and to put ourselves on the line and to undertake that experiential learning. I'll close, folks, with just a couple of specific case studies. Since 2012, a research team that I oversee at UNBC has been looking at creative arts-based methods and methodologies as ways to work with and document and record Indigenous voice and perspectives on health inequities. We found those to be remarkably powerful modalities for engagement, making clay masks, playing music, sketching, telling stories, singing songs. These sort of creative methods and methodologies can be powerful ways of understanding Indigenous voice and perspectives about health discrimination, anti-Indigenous racism. They really provide phenomenal insight, I would argue, into the multifaceted realities of Indigenous lives, and they can be very resilient and non-deficit modalities in Indigenous communities. So just for those of you who might be interested in innovative research and research methodologies, I would recommend you can just Google Health Arts Research Center, HARC. We have a whole series of worksheets and suggested art and creative interventions and work for creatively engaging with questions of Indigenous well-being. So these are certainly reaching some success. For those of you who are medical or health educators, the evidence is absolutely unequivocal that critical self-reflection is an integral component of cultural safety. So students that I've worked with and continue to work with are publishing papers on critical reflection and community immersion for culturally safe practices. Again, please do, if you have the inclination, take a look at those. And I know that you were offered some readings ahead of this webinar. I know I always do my homework prior to public lectures, so I trust that you've all undertaken the readings, but if not, those are all available for you to peruse at your leisure through this webinar. So there's the website for the Health Arts Research Center. I'll just tell you very briefly because this totem pole has appeared on a couple of slides. It appears on the cover of a book that Margot Greenwood, Charlotte Lopi, myself, and another woman named Nicole Lindsay have just co-edited on the determinants of Indigenous people's health in Canada. The pole is carved by Wet'suwet'en hereditary chief in Kispiox, Yaya Hiait. It's a contemporary example, I would argue, of the most powerful nature in terms of Indigenous creativity intersecting with Indigenous health. The poll is entitled Me and My Two Dead Brothers. It's a reflection on two of Yaya's tribal brothers, both of whom passed away of AIDS and HIV. They came back to Kispiox to die in their community. And if any of you are so inclined, do go and get the book. Yaya has introduced the entire textbook with a poem about his brothers and a poem reflecting on the pole that he carved, which sits in Kispiox. So just really, I would argue, a way of accessing and learning about Indigenous perspectives through creative expression as one modality of expanding, hopefully culturally safe healthcare practices for the future. So folks, with that, I will end. This is my email. I'm fairly punctual at responding to emails, but I get about 200 of the suckers a day, so I'm not ignoring you if I don't respond within 10 minutes. But sometimes I've got little breaks in my day and I just jot back responses to people. Please feel free to be in touch, or of course be in touch with the National Collaborating Centre for Aboriginal Health, and through them you're welcome to be in touch with me. Thank you so much, all 308 of you who are still on the line, for seeing this webinar through with me. It was a real honor. I'm sorry I couldn't see you all face to face. Thanks.